Hi, I'm Dr. Peter Merkel. I'm a professor of medicine and epidemiology at the University of Pennsylvania in Philadelphia. Where I'm the chief of rheumatology, and I've been conducting clinical translational research in vasculitis and scleroderma for about 30 years. Today I was privileged to be invited, and I was delighted to take part in the Association of Women in Rheumatology conference today, which is terrific. I talked about two topics in vasculitis: giant cell arteritis and polymyalgia rheumatica, and ANCA-associated vasculitis. And my job was to talk about updates in treatment. And I'll start with giant cell arteritis and polymyalgia rheumatica. We've seen significant advances in the treatment of giant cell arteritis based on a limited number of but high quality clinical trials. There are a number of different drugs in development and things that we've shown. So we're trying to move beyond glucocorticoids. And my main message is we have options for that. Glucocorticoids work well, but they have a lot of toxicities, especially in older patients who get giant cell arteritis. Tocilizumab is clearly an advance. Great good trial, and another smaller one shows benefit. Not all patients benefit. Some patients can't tolerate it, but a lot of them do very well and are able to spare some glucocorticoids. Some spare a smaller amount and some not so much. So it's really about the individual patient. One of the issues that come up is how do you stop the drug? That's a different problem, but it's a happy problem because we have alternatives. Methotrexate is still an option for patients. It's still part of the guidelines in many groups, and it's still an option, but perhaps not as strong evidence as for tocilizumab. A newer player is upadacitinib, a selective JAK1 inhibitor. I was part of a trial that looked at that. Those data are not yet published, but they have been presented, and I showed some data there showing the benefits of upadacitinib 15 milligrams daily in patients with giant cell arteritis. So what we're beginning to see is multiple different drugs with different mechanisms of actions working in the same disease. And they're not that different. So, example, JAK1 inhibitors still impact IL-6, but other things as well. And this is not uncommon in rheumatology. We've seen in our other diseases, we see different mechanisms of actions that work for the same disease. I think these are good problems. We'll be able to sort out options for our patients that works best for the person in front of you. In terms of polymyalgia rheumatica, glucocorticoids highly effective, but low-dose chronic glucocorticoids still have associated toxicities that can be significant and additive, and some patients just need doses that are just not acceptable, both for giant cell arteritis and for polymyalgia rheumatica and many other rheumatic diseases. A recent trial looking at sarilumab, a different IL-6 inhibitor, was positive and showed benefit in patients with polymyalgia rheumatica. So this is now an option either to start up front in patients who might be particularly prone to toxicity from glucocorticoids, which are many patients, or later if they're having trouble coming off or need to stay on doses that are unacceptable. And for some patients, any doses. So these are happy problems with options. Are there other drugs in development for these disorders? There are. And I think this is an exciting time to see if we can get better options for our patients. Most importantly, patients need to be followed carefully for emergence of new problems and complications. We shouldn't be afraid to reduce therapy, but we want to watch the patients very carefully, and they need rheumatologists, and we need our patients to work with us together. We can do better, and we are doing better.